Good morning, everyone. This is Mark Erkin, joining you from Mount Sinai in New York, and welcome once again to TIRO MDS. I have the pleasure this morning of introducing Dr. Minerva Romero Arenas, who is an endocrine surgeon and general surgeon at New York Presbyterian Brooklyn Methodist Hospital. She is an assistant professor at Weill Cornell Medical Center. She completed her fellowship training in endocrine surgery at MD Anderson in 2016. She is originally from Mexico City and is actively involved in a wide range of medical organizations. Quite an impressive list, including the Association of Women Surgeons, the Tour for Diversity in Medicine, Latino Medical Student Association, the National Hispanic Medical Association, and an organization called Building the Next Generation of Academic Surgeons. She's a founding member of the Latino Surgical Society as well. Her lecture this morning is entitled Safety, Efficacy, and Feasibility of Outpatient Thyroidectomy, a very important topic and something which has emerged as pretty much, I would say, the standard of care across the board here. We are also joined this morning by a frequent member of our panel, Dr. Camilo Gonzalez Velasquez, who will join me in asking questions to Dr. Arenas at the end of her lecture. Please, as always, feel free to send in your questions. We will try to get to those to as many of those as possible before the 9 o'clock hour. So once again, thank you to everybody for joining us, and thank you to Dr. Arenas for providing this lecture.
Wonderful. Thank you so much for having me. I'm really excited to be joining you today, and we'll go ahead and get started with the slides. So I'm thankful for the opportunity. I have no disclosures to make. And so today I want to get through a few key points about outpatient thyroidectomy. It is a well-tolerated procedure. It's a safe alternative for selective patients. And the patient selection really should follow all the available clinical guidelines. Some of the considerations for inpatient thyroidectomy versus outpatient will include clinical, social, procedural, and systemic factors. And a primary driver towards outpatient thyroidectomy is related to cost savings and resource utilization. And it's important to note why some of these factors are being considered. So we'll talk about thyroidectomy, and I want to just outline that we're talking about thyroidectomy, but we're really discussing it in the setting of total thyroidectomies, thyroid lobectomies, also any patient who undergoes completion thyroidectomy, and a combination of lymph node dissection that occurs frequently with these procedures. This is also a consideration for patients undergoing parathyroidectomy procedures, and this can be both for benign and malignant disease. We know that approximately 93,000 thyroidectomies are performed in the US each year, and so we're talking about a high volume operation. There's really been a shift over the last 2 decades from inpatient to outpatient thyroidectomy. You can see using this bar graph that the shift to outpatient thyroidectomy has increased, and it's also driven by the distribution of insurance status with the shift in Medicaid and Medicare insurance status becoming a greater portion of the outpatient thyroidectomy over the last few decades. So internationally, there's really no significant incentive to experiment with outpatient surgery. This has been demonstrated in surveys of various surgeons representing over 50 countries. And it really, what we have found is that outpatient thyroid surgery is most frequently performed in the United States, although other countries are also starting to evaluate the cost associated within their own healthcare systems and the factors that may help identify appropriate patients for surgeries in taking into consideration local factors. But so the majority of what I'll be discussing today is really applicable to the United States. And it's important to keep those considerations in mind as I know that this material will be available to an international audience. So some of the key factors that we consider for outpatient thyroidectomy include whether the procedure is considered safe in relationship to an inpatient procedure, which traditionally had been the standard of care. Obviously, the cost effectiveness, and what are the benefits? Are there any benefits besides cost savings? Also, there have been changes in our clinical practice guidelines that have also facilitated greater consideration of outpatient thyroidectomy in terms of the extent of surgery and the extent of treatment that we are offering to patients. So we'll talk about a variety of factors, including the indications for considering outpatient thyroidectomy, and then we'll go through some of the clinical, social, and procedural factors that can impact the decision and factors that can be associated with greater complications. So some of the factors that we want to consider in terms of the surgical trends include the cost. That's a huge driver in the United States. We know that there is a rising cost of healthcare with annual expenditures going over $1 billion annually. And so there has been a lot of attention about how to mitigate these costs. These include enhanced recovery protocols that can help reduce length of stay. Those will include a variety of factors such as perioperative management of IV fluids, of perioperative analgesics, including multimodal anesthesia, factors such as early ambulation in order to help the patient meet certain criteria for safe discharge. In addition to reducing the length of stay, we have also seen the transition of procedures to more of an outpatient basis. And this is largely driven, this has largely driven the change in thyroidectomies, more of an outpatient procedure rather than the overnight stays. We also talked about the clinical practice guidelines, and the American Thyroid Association, as well as the American Association of Endocrine Surgeons, has released guidelines that have really driven changes in our surgical and medical management. This includes increasing conditions where lobectomy is now considered an acceptable treatment for a significant number of thyroid cancers, specifically the change in the 2015 guidelines that allowed thyroid lobectomy as an acceptable treatment for differentiated thyroid cancers that were 1 to 4 centimeters, as opposed to the previous guideline that indicated total thyroidectomy for any patient with a thyroid cancer over 1 centimeter. In addition to this, there's been an ongoing change in lower indications or less indications for giving patients radioactive iodine. This has also driven the increased rate of lobectomy and decreased the number of completion thyroidectomies that are performed in order to help patients achieve status where they will be able to receive radioactive iodine. So both of these are some of the changes in our clinical practice that have really shifted to a lesser extent of surgery and therefore less invasive and better consideration for potential outpatient thyroidectomy. In terms of the surgical setting, a lot of research has focused on the comparability or non-inferiority of inpatient versus outpatient surgery. And we'll talk a little bit about some of those outcomes, but in reality, being able to see that there was no significant difference has heavily driven the shift towards outpatient surgery. We also have to take into consideration the volume. And when we look at surgeon volume, its higher volume is always associated with improved outcomes and lower complications. And so that also is a factor to consider in terms of whether or not patients are appropriate for outpatient procedures. We have also seen differences in rural versus urban settings. in terms of the resources that are available to the patient, the types of surgeons that are performing these procedures, and also factors that institutions and medical healthcare teams should be considering. Last but not least, there are specific patient factors that influence the outcomes after thyroidectomy. And there are a few specific factors that we'll go into more detail, but patients who are male, patients who have cancer, particularly more aggressive subtypes, and their comorbidities have also been associated with higher risk of complications, higher risk of readmission, and of course of increased healthcare costs. And so all of these are items that we should be considering in terms of deciding protocols for how to manage outpatient thyroidectomies and which patients may be more appropriate for an overnight stay or may require the support of having an overnight stay. So when we delve a little bit into more detail for the cost of thyroidectomy, we have found that higher comorbidities for the extent of surgery, including total thyroidectomies and patient undergoing lymphadenectomy, as well as the location. It has been shown that surgeries performed in rural settings and in the Western states have been associated with higher costs of care. And also patients who have postoperative complications, certainly it goes without saying that that's associated with higher costs of surgery. In addition to this, there are communities that are considered higher health risk. For example, the southern part of Texas is considered one of the highest expenditure areas in the US, with patients having high comorbidity, lower insurance status, and highly rural setting. So considering the community factors, these also tend to be areas where there are lower volume surgeons performing the operations. And that can also have an impact on the higher cost associated with these operations. I would say not just thyroidectomy, but other surgical care in general. And these factors can also contribute to the higher readmission post-op complications and a longer length of stay, particularly considering patient comorbidities and how that impacts all of this. As I mentioned before, patients, male patients and patients who have cancer have also tend to have more aggressive disease, may require greater extent of surgery. And these are factors that will also contribute to the increase in costs of thyroidectomies. In addition, the complication rates that we discussed and patients who have managed healthcare insurance. In terms of outpatient surgery, there's been data that demonstrates diminished costs for outpatient surgery. The expenditures for Medicare and surgical care annually exceed $120 billion. And in outpatient surgery, we have seen from 1996 to 2006, a 61% increase in the volume of outpatient surgery. Overnight observation tends to be more common than same-day discharge, although both are considered outpatient procedures. You can see about 2/3 of the patients actually undergo a less than 24-hour stay. And the cost difference between these two is about $1,500, with overnight observation having a median cost of $6,000 versus same-day discharge procedures having a median cost of $4,600. Now, we talked about the guidelines and the impact that these had on clinical practice. And there were a few specific statements that have helped drive some of these changes. This includes a specific statement on outpatient thyroidectomy that was published by the American Thyroid Association. And as I mentioned before, the ATA guidelines in 2015, looking at the management of differentiated thyroid cancer, and the series of guidelines that followed actually. So the ATA statement on outpatient thyroidectomy gave specific criteria to be used for consideration of outpatient surgery. And this specifically looked at a variety of risk factors, patient demographic factors, social and systematic factors, as well as giving us essentially our eligibility criteria and the relative contraindications to performing outpatient surgery. In addition to this, the ATA guidelines changed the surgical management of differentiated thyroid cancer, as we mentioned, allowing thyroid lobectomy for patients with thyroid cancer that fell within the 1 to 4 centimeter 1 to 4 centimeter size. Certainly, there is specific selection for the surgical management that would include no family history, no history of radiation exposure, no personal prior history of thyroid cancer. And as we mentioned, the changes in the indications for radioactive iodine, which have led to decreased treatment with radioactive iodine. All of this have had a tremendous impact on our clinical practice, and therefore allowing more consideration of a lesser extent of surgery and thereby more consideration for outpatient procedures. Looking at the complications of thyroidectomy, we see fewer complication rates in the outpatient groups than inpatient groups. This certainly has a selection bias, demonstrating, I think, the selection of perhaps healthier patients, of patients who are undergoing less extensive procedures than those who do require an inpatient stay. However, when we look at patients who undergo either inpatient or outpatient, there really has been shown to have no difference in readmission or reintervention rates in the patients undergoing outpatient thyroidectomy. And ambulatory surgery patients were less likely to experience readmission within 30 days than those patients undergoing inpatient surgery. Some of the factors that were associated with the unplanned readmissions or reoperations included factors such as patients who were on hemodialysis at the time of their operation, patients who had chronic steroid use, patients with unintentional weight loss, higher ASA classifications, which again speaks to the comorbidities of the patients, patients with active bleeding disorders, which, as we know, can have an impact on the rate of hematoma, and perioperative complications such as venous thromboembolus and DVTs. So some of the factors that we consider, as we discussed, include the indications for the for outpatient thyroidectomy. If we start out looking from the left side, we really want to consider patients who have no major comorbidities and patients who have lower ASA scores. We want to make sure that education is provided to the patients, to their family members as well, their support system, in terms of what will happen in terms of the management and specific factors that they need to look for, signs and symptoms for which they should seek reevaluation. We really need to consider a team approach to the education and the clinical care, and that includes everyone on the team, including the perioperative nursing staff, the patient care education team, even our operators and answering services, making sure that that communication in the outpatient setting is going to be safe for the patient to be able to seek reevaluation if necessary. One of the things that's key is that the patient must have a primary caregiver who is willing and available to provide assistance on the night of surgery for patients who are electing to have same-day discharge. And again, having a social setting that's conducive to a safe postoperative environment in terms of making sure that the patient will be easily able to return to the hospital if necessary, meaning they are able to seek reevaluation. In terms of the proximity, we know that a lot of patients may seek to travel for their procedures. And so when we consider patients who may be traveling from a different city to seek their operation, it is important to keep them within a safe distance of that procedure. And a lot of times this means for the patients staying at a hotel overnight. And I think most importantly, it is important for the surgeon to have the experience and the comfort in managing patients on an outpatient basis. So when we look at relative contraindications and the factors that can be associated with higher complications, as we mentioned, there is a variety of factors that include our clinical, our social, and procedural values. When we look at clinical patient factors, patients who have uncompensated disease, such as cardiac or respiratory disease, are at higher risk and should be considered for additional monitoring. Maybe patients who are not going to be our top choice for having an outpatient procedure. Patients who are on dialysis, as we mentioned, have been found to have higher risk of complications and do need a lot of perioperative management of their renal physiology. So those are patients where second consideration for an ambulatory surgery should be considered. Perioperative management of anticoagulant medications should be at the top of anyone's list regardless, but these are also factors that can contribute to negative outcomes. Patients who may have specific clinical comorbidities such as seizure or anxiety disorders, patients with sleep apnea are also patients who may be at higher risk. And then a series of potential disabilities such as hearing loss, visual impairments, patients who may have mental impairment, patients who are not independent in their day-to-day functions. Additional considerations should be made for patients who are pregnant and may need perioperative evaluation of the fetus. Patients who are on steroids who may be at higher risk of perioperative complications in regards to their hemodynamics, physiology, and wound complications. As we mentioned, patients with higher comorbidities based on their ASA classification, patients with underlying coagulopathy disorders, and patients who are at risk based on their age alone, patients who may have dependents for their activities of daily living. One of the factors that can also contribute is their smoking status. As we know, patients who are actively smoking or have quit within a certain period of the procedure may be at higher risk of having a variety of complications, including respiratory complications. When we look at the social factors, as we mentioned, the distance from the skilled facility that will provide any kind of emergency care is important. And patients who do not have anybody living in their home, it's important to have someone who will be able to stay the night with them or who will be able to travel with them to the facility performing the procedure. Patients who lack transportation are also patients that may not be able to go home on the same day, again, due to the risk of returning to the hospital. Certainly, patient preference has to be taken into consideration. And as I mentioned, internationally, there really has been no driving factor. Part of this could also be cultural expectations of the perioperative recovery around surgery. Patients may just simply not feel comfortable having to manage a lot of the postoperative care the first night of surgery on their own, or may not want to place this burden on their families. Any patients with communication barriers, such as limited English proficiency, patients who may be deaf, mute, or visually impaired, are also patients that we may want to consider additional support may be necessary and may not be appropriate for outpatient management. And patients who are considered minorities, largely driven by the fact that there are socioeconomic factors related to all of the factors that I previously mentioned, and may place these patients at higher risk of not being able to manage on an outpatient basis well. In terms of the procedural or the disease-specific factors that can affect our outpatient thyroidectomy, these include patients with larger or massive goiters, patients who have a substernal component to their goiter, certainly any patient that would require a partial sternotomy, for example, is not going to be a patient that is likely to have any kind of outpatient and will need an inpatient stay. But even if we are able to do a transcervical approach for the substernal component, those patients are likely to still have higher risk of hematoma, seroma formation, and may have higher needs for perioperative analgesics. So those are also factors that we want to take into consideration. Patients with locally advanced cancer can also have a higher risk, particularly when we're looking at some of the more aggressive histologic subtypes that may have adherence of the disease to some of the local structures and may require additional monitoring based on the gross extent of the disease. Any patient who has any challenging in obtaining hemostasis and any concerns for bleeding should be considered relative contraindication. As we know, the risk factor for thyroidectomy, particularly in terms of having a postoperative hematoma that requires reintervention. The majority of these, despite the low frequency, the majority of these hematomas will become clinically apparent the first night of surgery and within the first 24 hours. And so any considerations about having challenging hemostasis intraoperatively should lead the surgeon to reconsider having the patient leave the hospital on the same day. Any patient with additional disease such as a difficult thyroidectomy based on Hashimoto's thyroiditis, Graves' disease that sometimes can be more sticky, any patient who is a reoperative patient, or patients who have undergone any kind of radiation therapy, not our favorite type of tissue planes to work with, but those are certainly considerations where perhaps a outpatient thyroidectomy may not be in the patient's best interest. One of the factors that we also want to consider is perioperative analgesics. And as we know, there was a large shift in having patients' pain managed in a greater number over the 90s and 2000s. Unfortunately, this also led to a shift in overprescribing perioperative analgesics. Now we're sort of having the pendulum swing back to mitigate the unintentional use of opioids. And so there is extensive data now demonstrating that patients undergoing thyroidectomy or parathyroidectomy are reporting low requirements for analgesics, and having a stage analgesic regimen can provide adequate pain control with patients having similar pain scores, whether they're receiving a non-opioid stage analgesic regimen in comparison to an opioid inclusive or opioid first approach for pain management. In reality, what we have found is that patients actually report the majority of their pain on their first 3 to 5 days after surgery. The majority of patients were able to have their pain controlled appropriately with a non-opioid analgesic. And this overall reduced their consumption of opioids by over 50% when they are given the choice to self-administer a non-opioid plus or minus an opioid medication. This certainly is a consideration for the surgical teams who are taking care of the patient and can provide one reassurance to the patient that their pain will be well managed on an outpatient basis. And secondly, in consideration of the resource utilization, it shouldn't have an increase, for example, in requests for additional prescriptions that may need the clinical team's attention after discharge. It actually, when prescribed opioid analgesics, most patients actually end up reporting that they did not use the majority of the prescribed prescription pain medications, and therefore this can be reassuring to both the patient and the clinician in terms of pain control. So with that, I would like to thank you again for the opportunity to present today, and I'd be happy to answer any questions that may have come up from the audience.
Thank you so much, Dr. Arenas, for your incredible talk. And I'm gonna, before Dr. Aiken takes the floor, I'm gonna allow myself to say 2 words in Spanish that everybody is gonna be able to understand. Muchas gracias. I really thank you for representing the Latino community. I'm sure the whole Hispanic medical community is proud of you. We are. So I have a couple of questions written down, but I'm gonna allow Dr. Aiken to jump in with the first couple of questions.
Yeah,
Thank you so much for those kind words.
Yeah, I would echo Camilo's comments, and really a thoughtful, well-delivered, thoughtful presentation. We do have one question from the audience regarding recommendations for anticoagulation and platelet and aspirin use perioperatively. Perhaps if you can comment on that in light of the issue of discharging a patient.
Absolutely. There's definitely a couple of things to consider. I would say as a surgeon, I would prefer to not have any antiplatelet or anticoagulant therapy for the patients. That's certainly a factor to consider. Depending on the specific medication, the period that is safe to stop it will vary. We know that aspirin, you want to stop 7 days prior to surgery. Other medications will require anywhere from 2 to 5 days prior to the day of the procedure of holding the therapy. And in terms of whether or not that's safe, I usually do defer that to the physician that is managing the therapy. Most of the time, this is really related to patients with peripheral arterial disease, for which most of the time it's completely safe to stop the medications briefly in the perioperative period. However, for patients who have cardiac disease, I do definitely defer that decision to the cardiologist, to the managing cardiologist. There are guidelines that have come out from the ACC and the AHA that delineates specific timelines and patient factors that should be considered for stopping antiplatelet therapy and anticoagulation therapy perioperatively. I would say that in general, for any patient who maybe the antiplatelet therapy, the aspirin specifically, is not able to be stopped, that hasn't proven to be too much of a burden for me perioperatively, particularly if the surgical technique is meticulous, including the use of both suture ligations and energy devices. Good hemostasis can be achieved, and that can not be as problematic. I would say that the other anticoagulation therapies are a lot more problematic in the initial perioperative period, and usually if there is a patient that for whom these medications cannot be stopped, then I usually take a second and really sort of rethink, why am I operating on someone who cannot tolerate having these medications stopped? If there is a definite contraindication to stopping it, then that usually is reflective of a greater clinical problem. And if the thyroidectomy procedure for some reason has to move forward, then I would say that's a patient for whom I would not consider outpatient surgery. And then just to sort of go back to the recommendations for antiplatelet therapy. Those are related to cardiac risks, such as patients who have had a heart attack within a certain period of time of the operation. And again, those medical comorbidities and implications for how to manage those patients, they may be safer to have perioperative telemetry monitoring, for example.
Great. Can you comment on the two options of overnight observation versus same-day discharge? How do you manage those folks? How do you decide one versus the other? And how often do you find in your own practice that you end up changing a plan from an anticipated same-day discharge to keeping somebody overnight? Just kind of what's your conversion rate?
So I will say that in my first 3 years of practice, I really did total thyroidectomies as an overnight stay or inpatient basis only. Thyroid lobectomies, I did as an overnight stay, and parathyroidectomies were dependent on the extent of parathyroidectomy. So targeted, minimally invasive parathyroidectomies, I routinely feel comfortable sending them home on the same day. Whereas patients who require four-gland exploration, I feel more comfortable observing them overnight. Some of the factors I take into consideration include my concern for hypocalcemia, particularly symptomatic hypocalcemia, depending on the extent of the operation. I don't want to jinx myself, but the risk of hematoma is less of a driver, but certainly something that I consider heavily, more so in the sense of what are the patient factors. So I can give you an example of my first few years of practice. We're in a rural community in South Texas where the patient population had high risk of surgery based on comorbidities, meaning I was operating on sicker patients at baseline. That would include obesity and other comorbidities such as hypertension, heart disease, but also in the rural setting, traveling, for example, from home to the hospital could be easily anywhere from 10 to 50 or 60 miles. And that is certainly, those are factors to consider. The shift for me, for example, moving to a city like New York City, is that patients are routinely just a couple of blocks away. And so that has allowed me a little bit more flexibility in being able to offer outpatient surgery, knowing that the patients are going to be more easily able to get to the hospital. However, this still largely is dependent on their situation at home and the patient's comfort level. Most of the time that I have had a transition from a planned same-day discharge procedure, it's either based on a change in the operation itself. And if that's a change based on, I was anticipating a lesser extent of surgery and shifted to greater extent of surgery, then I generally do discuss that with the patients and their families. And that tends to be something where I shift to maybe keeping them overnight based on a change in the surgical plan. And particularly if it's something that for some reason was not anticipated. And then two, in terms of the situation at home, it just so happens occasionally that patients, family members may ultimately have competing responsibilities that maybe are not going to allow them to stay with the patient. They may not be able to, for example, come back to pick them up in a timely manner, or they simply do not feel comfortable with taking the responsibility of the care and awareness that it requires to be responsible for for recognizing an emergency. And so in those cases, I'm always willing and I think it's the safest for the patient to go ahead and stay in a setting where they will be closely monitor.
Great. What are the unique differences about being in a metropolitan area such as New York, and I'm sure Houston, is the recurrent relates to the recurring nightmare that I used to have when I first started doing outpatient thyroid surgery, which is having a patient stuck in a tunnel or stuck on a bridge and having an expanding hematoma. There were many a night that I would wake up with that recurring dream or nightmare, and fortunately, that really has never happened. But that's certainly one other consideration. What is your current practice when you're doing same-day discharge? How long will you observe a patient before sending them home?
The observation period post-operatively for same-day discharges for me varies anywhere from 3 to 6 hours. That is based on specific criteria that I've delineated to the team. Routinely, I will tell patients, one, that we have to have the general anesthesia criteria for discharge meds, such as control of their postoperative nausea and vomiting, making sure that they're not experiencing urinary retention, and then certainly that they're able to demonstrate that they're going to be able to keep themselves well hydrated, able to safely eat and drink, and be able to ambulate on their own. In addition to that, as I mentioned, I do try to make sure that the pain will be well controlled. And this requires a lot of education, both in the clinic and prior to the day of surgery, reinforcement at the time of the morning of surgery, as well as in the postoperative instructions to the patient.
Great.
And
What,
Dr. Aitken,
yeah,
just
go
a
ahead.
quick question. In
Yeah.
that same train of thought, do you have like a workup that you do after the surgery before you discharge a patient? And I'm particularly interested in how you evaluate calcium levels before
Sure.
discharge.
Yes, so for thyroid lobectomies, I don't routinely worry about calcium or parathyroid issues, and so those patients kind of have a green light for that. For patients who have parathyroidectomy or total thyroidectomy, I will have a post-operative calcium and PTH drawn in the PACU. That generally helps me evaluate the extent of the calcium drop that I see. So I know that I generally consider patients who have a 1 unit drop in the calcium levels from the pre-op to the post-op are going to be a little bit higher risk of experiencing symptomatic hypocalcemia. And then I also look at the PTH level in terms of helping me decide patients who maybe are going to be at higher risk of experiencing hypoparathyroidism, which usually peaks about 2 to 3 days after surgery. And so when I look at those factors, then I will consider whether the patient should be instructed to take calcium as needed, meaning only if they experience symptoms, or whether I think someone is going to need to be on standing calcium supplementation sort of as a preemptive based on the whatever levels that I'm seeing. And if I see, if I have any concern that they are maybe already experiencing or maybe showing signs, then I may elect to keep those patients because, as you know, having muscle spasms and greater symptoms of hypocalcemia can be very troublesome and highly concerning to the patient. Sometimes they will require IV calcium infusions depending on how low that calcium level goes. And so for those patients, it may just be better to offer immediate support in the hospital.
So with that in mind, give me a ballpark in terms of what postoperative PACU PTH level you start to get worried about?
Yeah, so this is going to vary a little bit by the laboratory reference range at your institution. At my current institution, the PTH normal range is of 18 to 65. So if I see it anywhere in that normal range, I generally consider that those patients are unlikely to have undetectable PTH by the third day. However, if I'm seeing undetectable PTH in the immediate postoperative period, then I'm more concerned that those patients are not going to immediately recover. And so those are going to be patients that I either send out on standing calcium or that I keep for ongoing monitoring and having an additional 1 or 2 levels, depending on their extent of operation, their physiology based on what I'm seeing in the recovery area.
And what about, you didn't mention lymph node dissection, in particular lateral compartment. Are those, you're placing a drain, I assume, in virtually all of those when you do lateral compartment dissection? Does that warrant an admission in your mind?
So I don't place drains routinely for lateral neck dissections. I do routinely keep those patients in at least overnight. The main driver behind that is that those patients do tend to have higher pain scores. They also tend to have more difficulty in terms of their recovery and their comfort level with mobility and their day-to-days. Also, depending on the factors that I see intraoperatively, particularly for bulky nodal disease, those patients may be at higher risk of seroma or even chyle leak. And so for those reasons, those patients tend to be more appropriate in my practice for an overnight stay. I have had more of those patients as an overnight stay than as a inpatient admission that is greater than 2 midnights. And so even the lateral neck dissection patients can technically be considered ambulatory if they're able to leave after 1 night in the hospital.
So the real nightmare that we all worry about is that expanding hematoma causing airway problems. How do you really judge that? How reliable local healthcare institutions that for a patient who would need to visit an emergency room or get care locally, how do you really make that determination that it's a safe thing for them to go to that institution? It's pretty tough, I would imagine.
I think it really requires a lot of education to the patient and to the family member regarding when they should seek care. As I mentioned, ensuring that they are in close proximity to the institution. And if, for example, I work at a teaching hospital, and so providing appropriate guidance and education to our residents who are going to be our first line to evaluating the patients in terms of how to manage them. There are protocols that have been described in terms of how to manage an postoperative hematoma, which include, depending on the patient factors, whether that hematoma is evacuated at the bedside, meaning, whether that evaluation is occurring in the emergency room or in, on the wards, versus transporting that patient to the operating room and evacuating the hematoma in the operating room prior to intubation. Certainly, that will be affected by whether or not the patient is experiencing significant respiratory distress. But in large series, it has been demonstrated that a significant number of patients actually can have the hematoma evacuated prior to re-intubation, and that tends to make the intubation process for the anesthesia team a little bit easier and also less stressful because the hematoma has been evacuated, and that tends to relieve some of the stress of having respiratory compromise.
Great. Camilo, do you have a question here?
Yeah, you were mentioning as part of the criteria or the way we screen people or filter those that are amenable for a outpatient procedure, being a minority and the language barrier, and living in such hub cities like New York, Houston, in comparison to McAllen, for example. And speaking of Houston, Dr. Naifa Busaidi is really happy to see you, and they say they miss you a lot down there.
I
How
miss
have
our
you-
team too. Thank you for joining us today.
How have you encountered that difference, like in those cities, or how does that change your practice? I mean, New York has a lot of minorities and different cultural diversity within one city. So I'm guessing, does that push you to more inpatient procedures more so than outpatient procedures?
I would say, one of my mentors actually routinely say to me, Nancy Perrier always said, grow where you are planted. And that, that really includes understanding the resources that are available. In McAllen, actually, the majority of the population there is Hispanic, and a significant number, I would say, at least 50% of my patients down there were primarily Spanish speaking. That being said, so was most of the hospital staff. Most of the answering services would easily be able to direct the patients in either English or Spanish. And so that tended not to be as much of a factor in that practice setting. But that was also more driven, my decision-making in that setting was more driven by the resources, both of the patient and their families. And as I mentioned, some of the clinical factors that maybe was going to influence their care more. Now in this setting here in New York, I would say understanding what I anticipate to be the risk that will drive whether, for example, I schedule the case in the ambulatory surgery center as opposed to the inpatient hospital. And then here I do definitely encounter a greater number of languages, just based on the diversity, particularly here in Brooklyn, where we have a very diverse community. And in a single day, I could find myself requiring translator services of 4 to 5 different languages. We do have the ability to have language translator services easily by phone and video chat, which as you may has been, I think, positively impacted by COVID in terms of really driving us to have better access to these factors. And so I would say, in terms of the minority status, that really tends to be tied to the socioeconomic factors and the social situations surrounding the patients.
Minerva, we have a question from the audience regarding your approach to calcium and vitamin D replacement. Do you have a specific protocol with respect to the decision to start someone? We sort of touched on this a little bit, but maybe you can elaborate. What doses do you recommend? And what kind of postoperative regimen for a discharge patient will you have them undergo in terms of getting calcium checks as an outpatient?
I don't have a published protocol, but there are several published protocols out there, so I cannot lay claim to any of them. It will depend on the specific procedure. As I mentioned, for lobectomies, I don't routinely check any labs. For parathyroidectomies, I will check for parathyroidectomies, for total thyroidectomies, reoperative thyroidectomies, completion thyroidectomies. All of those are patients who will get a calcium and PTH and PACU. I don't routinely start calcium on patients unless I have a specific concern. And I usually start with a 1,500 milligram twice a day, depending on the extent of calcium drop that I see. For example, if I see a patient go from a calcium of 11 to a calcium of 9, even though the calcium of 9 is technically in the normal range, it lets me know that their body is already detecting that change in the hormone and driving the calcium, for example, out of the blood and into into the bones, I guess. And so even if I see a normal calcium range, I take into consideration that large drop, and those are patients that I may have go ahead and start on supplementation, anticipating that they are likely to need it in the next few days after surgery. I also, for patients who have secondary hyperparathyroidism, where the renal disease is a large driver of the calcium and parathyroid physiology, those are actually patients where the calcitriol is actually prescribed even prior to the day of surgery so that the patients have it readily available. Those patients are routinely actually more managed on an inpatient basis based on their need for dialysis, but also their higher risk of pretty significant hypocalcemia. But I will routinely get that medication prescribed because it often requires pre-authorization from their insurance companies. So those are some of the patients that require additional attention in terms of the perioperative calcium management.
Great. Camilla, do you have other questions?
Well, I wanted to ask you, Dr. Aitken, in your experience, it's been years since we've been discussing the low volume versus high volume dilemma and the number of complications that could come out of that. So I would like to ask you, like, having observed other junior physicians or other surgeons earlier in their career, have you seen the rate of conversion, if we could call it that, like having people extend their stay in the hospital, be really different based on their years or their volume of surgeries?
Yeah, I think I think Minerva touched on this. That kind of that level of being conservative at early in one's career, I think, is certainly wise. And I think as you go on and you gain that level of comfort, I think that most people will start to adopt similar set of guidelines to what was beautifully outlined today. So I think the level of experience should be a factor for a surgeon to make that determination. But over time, I think that personal experience drives so much of what we do as with respect to intra and postoperative care.
And that is really interesting because most of the times the power of what a physician, a surgeon, or whomever in the care team has on the patient is very strong. And it's difficult for us to have an insight and see ourselves as a high or a low volume caregiver. And that's not taking into account. It's almost, it seems like the certain care teams should be labeled as high volume, low volume, to see, because you see that that's not a factor that the patient actually takes into consideration prior to surgery. And the way that you present the procedure might of course change the way that they choose to be treated.
Yes, I think that's interesting. I don't think that will happen necessarily, certainly not in the United States here. But certainly, I think obviously one being honest with oneself about their own capabilities, I think, is extremely important. We are pushing up against the 9 o'clock hour, and certainly want to take this opportunity to thank Dr. Arenas for an outstanding presentation, outstanding discussion with a lot of wonderful insights into this extremely important topic. So with that, I want to invite everyone to come back next week for a lecture and a discussion on the topic of active surveillance to be given by Dr. Anna Saka. So everyone, we started this program back in March of 2020, when at the height of the pandemic. Unfortunately, it hasn't left us completely. So everybody stay safe and have a wonderful day. And thank you for tuning in. Take care. Thanks again, Dr. Arenas. Thanks, Camila.
Thank you so much.